Okay, good afternoon, everyone. Once again, thank you for joining us for our webinar on approach to carotid artery disease. So before we begin, I'd like to say a few introductory remarks about Yetena Weg. So Yetena Weg is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members. We currently have more than 70 active volunteer members spanning across 5 different countries, counting more. And as you can see from the image on the right-hand corner of our slide, it's an image showcasing our volunteers at work. So our projects and engagements can be seen in 4 aspects. The first is health promotion, which is done via discussion and articles concerning the health of the general public, health policy and its implementation. Our second project is community engagement. So this is done through blood drives, inclusivity, trainings, equity projects, and fundraising campaigns. Our third and one of our strongest is our mentorship and skill sharing project, where we provide direct mentorship, soft skill, career and professional development webinars for healthcare professionals. And the last project is the medical education, which under it has the CME and research and quality improvement projects. So Yetena Weg is more than a digital platform. It provides a space where volunteers can come together and contribute to the society in a meaningful manner. So this is another slide showcasing our volunteers participating in our various activities. So our other engagement is the Yetena Weg Roha Health Article Writing Competition. So the first round of health article writing competition, which is organized in collaboration with the Ethiopian Medical Students Association, IMSA, and the Roha Health Foundation, has been announced on September 2. Roha Medical Campus, through its Roha Health Foundation, will award travel grants for 2 health article writing competition winners, whereas Yetena Weg will award approximately for the top 20 and litmus score for the top 3 winners. And the top 5 winners will get internship opportunities at Roha Health and other partner institutions. So if you've been following our social media outlets closely, these are the posters we've used to announce the research, the article writing competition. So this is a slide showcasing the 2021 article writing competition winner and the prizes for the 2022 competition. And this is another slide showcasing the 2023 article writing winners that got the opportunity to travel abroad to the University of Global Health Equity. Our other project is the Yetena Weg Research Fellowship, which is done in collaboration with Tikur Anbessa Specialized Hospital and St. Paul Hospital Medical College. So the first round started on March 14th, 2023. So at Addis Ababa University Medical Faculty, 3 departments, mainly oncology, radiology, and internal medicine, got the opportunity to compete. And research grants for the top 4 winners has already been provided. The other round was done in collaboration with St. Paul Hospital Medical College, mainly for medical students, interns at the time. So research grant has been awarded for the top 4 winners. This is a slide showcasing the winners from Tikur Anbessa Specialized Hospital, and this is another slide showcasing the winners from St. Paul Hospital Medical College. So when we come to our CME sessions are freely accessible, and Yetena Weg partners with the Ethiopian Medical Association, the Ethiopian Society of Cardiac Professionals, and the Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. We invite renowned local and international speakers. We've had 27 CME webinars so far for the year 2024, and our average webinar attendee varies from 150 to 200 healthcare professionals. And for the year 2024, we've planned to have more than 30 webinars focusing on emergency surgical and medical cases, ENT, pediatrics, OBGYN, and more. So you can access our previous CME sessions by going to the Yetena Weg YouTube channel, and you can get updates about our upcoming CMEs by joining our social media outlets. The links will be pasted in the chat box shortly below. So to get the best experience in the webinar, we urge you to send your questions to the Q&A or directly to the chat box. And at the end of the webinar, your questions will be addressed by the guest speaker accordingly. And in order to get CEU certificates, you must fulfill the following set of criteria. The first is attend the whole session virtually. The second is fill the Google form for personal details in attendance. And the third is get 50% and above on the post-webinar quiz. So you may get your result right away. The certificate will take up to 2 weeks to be delivered to your email. So we ask that you wait patiently in the meantime. Having said that, I would like to introduce our guest speaker today. Our guest speaker today is Dr. Dawit Gebregiorgis. He's a consultant general in vascular surgeon and an assistant professor of surgery at Addis Ababa University College of Health Sciences. He earned his subspecialty certificate in vascular and endovascular surgery in 2023, following his subspecialty certificate in surgery in 2020, was from Addis Ababa University. So Dr. Dawit has extensive experience in trauma and field surgery, having served in conflict regions with active wars. His professional career also includes a significant contribution to academia, where he has held various teaching roles, including lecturer and surgical president since 2015. In addition to his clinical and teaching duties, Dr. Dawit worked at various institutions, and his academic achievements are complemented by numerous training certificates, including advanced courses in medical education and scientific training. He is a published researcher with works focusing on vascular trauma and the pattern of vascular disease at Tikur Anbessa Specialized Hospital. He is an active member of the Surgical Society of Ethiopia, the Ethiopia Medical Association, and the Ethiopian Red Cross Society. Without further ado, I would like to welcome our guest speaker. Dr. Dawit, please proceed.
Okay. Thank you, Adil, and also the audiences. So I'll just directly jump into our today's discussion, which is going to be, as that Adil said, it's going to be about approach to carotid artery disease. Okay. So this is going to be our outline. So I'll start with some introduction and anatomy of the carotid artery in general, and we'll see its relation to the adjacent organs, and then we'll jump into directly to two specific pathologies, which is going to be about extracranial cerebrovascular disease, which is one of the most common causes of morbidity and mortality in the whole world. And next we'll discuss in detail about carotid body tumors, which is specifically much more common in our setup. So to say some introduction, and now in general, when we talk about the surgical aspects of this carotid artery disease, we have to always know about its anatomy. Okay, so as we have discussed last time, I'm going to repeat it now. So after the aorta gives a branch to itself, which is a coronary artery, the next big branch which gives is the brachiocephalic arteries. Okay, so as you can see over the picture, so as you can see the picture first on the right side, there is brachiocephalic artery, which gives a branch to the right subclavian and right carotid arteries. Then it gives specifically to the left carotid artery, which branches from the arch of aorta, then the left subclavian artery. So this carotid artery is more important because, the brain is the most important organ, and it cannot survive without oxygen and glucose more than a few seconds or few minutes. So a disease which affects the supraortic trunks can be atherosclerotic lesions, aneurysms, arthropathies, trauma, and tumors. Most of these diseases are mainly, addressed by a surgeon, specifically a vascular surgeon. That's why we are specifically talking about these lesions. As a medical aspect of specifically the atherosclerotic lesions, it might be dealt by the internal carotid, the internal medicine specialists, specifically neurologists. So this is just to show you the axial or the cross-sectional anatomy of the neck, which shows you that there is a carotid sheath. Within the carotid sheath, you have mainly the jugular vein, the carotid artery, and also you have the vagus nerve. So this is the lateral view of the anatomy. As you can see, deep to the cleidomastoid muscle. When you remove the cleidomastoid muscle, you see the artery, which is situated on the medial aspect of the neck, and it gives anteriorly the external carotid artery, which is, it has many branches and it supplies the face. But the internal carotid artery, specifically the neck part of the internal carotid artery, it doesn't have any branches on the neck. This is it's just to show you its relation with neurovascular structures. As you can see, the hypoglossal nerve crosses both the internal and the external carotid arteries. As you can see, there is also a glossopharyngeal nerve, and you have also anteriorly, this is ansa cervicalis, which supplies mainly the platysma, which is deep to the subcutaneous tissue, and also we have the accessory and the glossopharyngeal nerves. So this is just a picture which shows you that how much important each sides of the carotid arteries are. And upon that, there is one main thing that we should forget, that which is the branch of a subclavian artery, which is the vertebral artery, which is also one of the major supply to our brain, mainly the posterior part of the brain. Then these circulophiles will be well developed in adults, but the problem is in almost 25% of the population, this circulophiles is not well developed, which means if there is any kind of stenosis or occlusion over one part of the artery, the likelihood of development of ischemia or infarction on the brain is higher. So this is just anatomical or surgical, classification of the neck. You have zone 1, which is, to the level of the upper border of the clavicle. You have zone 2, which is mainly accessible to the surgical, whenever there is trauma or any kind of, elective procedures. Then you have zone 3, which is difficult a little bit to do open surgeries. I'll come back to this when we talk about, interventions later on. So let's dive into the specific pathologies. The first one is extracranial cerebrovascular disease, which is mainly I'm talking about atherosclerotic lesions of the carotid artery, specifically the internal carotid artery. So our main objective in this pathology is going to be to understand the natural history of extracranial cerebrovascular disease, and to discuss the parameters which influence our decision to install any kinds of treatment. It could be open surgical, it could be only medical, or it could be minimal invasive endovascular intervention. So when we talk about cerebrovascular disease, we are mainly talking about stroke, but it's not only about stroke, because stroke is a full-blown neurological deficit. But in general, when you define this stroke or cerebral infarction, it is just an acute development of a focal neurological deficit, which is caused by disruption of blood supply to the brain, which means there is an occlusion over the internal carotid artery mainly. But mind you, an occlusion over the vertebral artery can also result in neurological deficit, but this neurological deficit is mainly over the posterior circulation, which mainly affects the not the cerebrum, but rather the posterior part, which is the cerebrum of our brain. So in general, this pathology is a major cause of mortality and disability worldwide, as I have said before, and its prevalence, which dates 10 years back, accounts almost for 250 million, which is 25 millions of a population is affected by this illness. And it has resulted in 5.5 million deaths and over 44 million disabilities every year, which is significant. And in US, it was documented that almost close to 1 million stroke appears every year. And the cost is, predicted to be more than 100 billion, which is more. So coming to the specific causes, most of the time the cause for this stroke is ischemic stroke, almost, more than 80% of the cases. But when it comes to Ethiopia, the cause for ischemic stroke is as half, because hemorrhagic stroke is also more common in this setup. So in our setup, stroke deaths accounts almost for a total of 6.2 of the total cause of deaths, which is about in-hospital deaths. So when it comes to the natural history, mind you, the prognosis of this illness, of this pathology, mainly depends on the presence of symptoms or the absence of symptoms, which means those patients who have a symptom will likely have higher morbidity and mortality than those patients without a symptom. So if the patient is asymptomatic, how do you diagnose? Most of the time, these patients, occasionally or incidentally, they will be diagnosed as having carotid artery, which is a turbulent flow when auscultate over the neck. So which is we have to put and point it out as a marker of systemic atherosclerosis, which means once you have found that there is an atherosclerotic lesion over the carotid artery, which indicates that there is a higher chance of having atherosclerotic lesions, in other vascular system. The risk of stroke in these asymptomatic patients is, almost more than 50% if the lesion is, or the stenosis of that artery is, greater than 50%. But if it is less than 50%, the risk of stroke is 3%, which is important because intervention depends on this, risk of development of stroke. And the other thing is, in terms of progression, these patients, I'm specifically talking about symptomatic patients, their progression is higher if the stenosis is higher. For example, if the stenosis is more than 80%, the risk of progression and having symptoms is higher in almost 1/3 of the population. Then you shouldn't always forget about silent cerebral infarction, which means the patient might be asymptomatic, but they might have embolization of simple embolizations without any symptoms, but they will have cerebral infarction. The other one you shouldn't forget is about the plaque composition. Okay, these patients, a patient who's having, like, for example, lower extremity ischemia, you might send this patient Doppler ultrasound, and on the Doppler ultrasound, the patient might have atherosclerotic plaque on ultrasound, but the description is a more important one, whether it is calcified or soft, which means if the patient has a calcified plaque or atherosclerotic lesion with a stenosis less than 50%, the patient has a less likely to develop a stroke. But if the patient's plaque composition is soft, which is a higher risk for rupture and embolization and also progression. So these patients have a higher chance of development of stroke within 2 years. Coming to the symptomatic stenotic carotid artery disease, the incidence of stroke increases whenever the patient becomes symptomatic, and this, increment in incidence is influenced by the severity of stenosis, like the symptomatic one, which means once the stenosis severity increases, the risk of a stroke will increase, and also the number of risk factors that the patient specifically is having. These risk factors, as health professional, one of these risk factors like diabetes mellitus, hypertension. We also have smoking, increased age. These all risks increases the development of stroke. So this is just a NACE trial which shows that the 5-year ipsilateral stroke from the specifically symptomatic stenotic carotid artery disease, it's as high as a quarter, which means almost more than 20% of the patients can develop with only a lesion or a stenosis of less than 70%. So coming to the pathogenesis, what could be the causes? Mainly, we are talking about atherosclerosis because more than 90% of the cases with carotid stenosis, the cause is atherosclerotic. But there are other possible causes like fibromuscular dysplasia, which is more common in young adult females, mainly who are in reproductive age groups. And the other causes could be dissection, it could be due to intervention, or it could be because of the atherosclerotic lesion, or it could be due to because of other vasculitis. The other cause could be Takai's arthritis, radiation arthritis, these patients who have medical therapy or radiation therapy to their necks, and we also have giant cell arthritis, and also kinking, coiling, and also carotid aneurysms. Carotid aneurysms in our setup, they are more common because of trauma. So the main thing is we should always consider their clinical syndrome. So these patients can be classified into 3 categories. As I have said before, the first category is asymptomatic patients. These asymptomatic patients are those patients who doesn't have any kinds of symptoms, plus those patients whose symptom has passed 6 months. The reason behind this, within the 6 months, this plaque will heal because of the natural course and also because of the medical therapy, and later on the risk of development of stroke will be as equal as asymptomatic patients. So we call them asymptomatic patients. And the other categories is patients with transit ischemic attack. Those patients who have symptoms less than 24 hours, which stays less than 24 hours. So these patients have a particular concern because these patients should be addressed not only with best medical therapy, but also with surgical intervention. And the third class is, those patients who have, full-blown cerebral infarction coming to you with full-blown stroke. So this all can be explained with, on the right side of the slide, you see that there are some other explanation and definitions of the clinical syndromes. So coming to the clinical assessment, as always, like any other patient, the history is the most important thing. So neurological history, if the patient has any kinds of, difficulty of speech, if they have any kinds of difficulty of, or having a weakness over the extremity is more important. And also have to identify whether this is a frontal lobe ischemia or, cerebral ischemia or cerebellar ischemia, because those patients with cerebral ischemia mainly present us with, difficult of walking, or vertigo, tinnitus, with any kinds of post-circulation symptoms. The other one is vascular history. As I have said before, those patients who have limb ischemia, they have a highly likely of development of this carotid artery stenosis or plaque. So these patients also should have thoroughly clerked and asked about their vascular history. The other one is a pre-description of the symptom. You see, as I've said before, the symptom should be clearly defined and specifically sort out whether this is because of atherosclerotic lesion with stenosis, or is it because of bleeding, or which is hemorrhagic stroke, or you should always be able to identify whether this is because of simple occlusion, or is it because of an emboli. Because those patients who are having embolic phenomena, they can have a silent ischemia, or they can have a full-blown stroke. And the management in an acute setting is a little bit different. The other one is, thoroughly you should be able to examine and assess their comorbidities, like cardiac comorbidity, and pulmonary and renal comorbidities, because it influences your management. The other one is, as I've said before, risk factor assessment is important, because the management also depends on these risk factor assessments, like smoking, hypertension, and diabetes mellitus. And coming to the physical examination, blood pressure management is the most important one, so you have to measure their blood pressure. The other one is vascular and neurologic examination, and also eye examination with fundoscopic exam. So this is just an image to show you that how a plaque progresses. This is, as you can see, there is a plaque with a stenosis of at the bulb of the internal carotid artery. You see there is a stenosis with some sort of an ulceration. Then this ulceration is prone to a disposition, which is a platelet deposition. Then this platelet deposition will progress into platelet emboli. This is a simple rule, like Virchow tried. Whenever a patient is having endothelial injury, or a hypercoagulable state, or which means or having a stasis, will result in a thrombosis of these vessels. So coming to diagnostic modalities, the most important diagnostic modality in this case is imaging, which is ultrasound, carotid duplex ultrasound, which should be the initial diagnostic choice. So ultrasound can tell you the physiologic phenomena that is occurring over these specific arteries. Okay, so the accuracy is more than 90% for diagnosis of internal carotid artery stenosis. So apart from this degree of stenosis, the imaging, which is the ultrasound, can also tell you that whether there is calcification or not, whether there is luminal irregularity or not, whether there is an ulceration, pattern of pathogenicity, because all these things are important for intervention. This is just to show you, the flow or the measurement of the velocity over the artery and its relation to the degree of stenosis. As I've said before, it is important to tell you the physiology of that specific artery. The other imaging modality could be contrast-enhanced MRA, which can show you, a better anatomic outline of the carotid artery. And usually we, use CT angiography. The problem with CT angiography is, it can be, it is important for anatomic evaluation, but it has difficult determination if the patient's artery is calcified. For these reasons, we might choose contrast-enhanced MRI angiography, which is the initial image. As you can see, there is proximal internal carotid artery stenosis when compared to the distal part of the internal carotid artery. The third one is digital subtraction angiography. This is a gold standard. It used to be, but the problem with this one is, unless you are going to intervene these patients with, endovascular intervention, it's not mandatory to have this digital subtraction angiography, because this is an invasive study. So we prefer to have CT angiography or contrast-enhanced MR angiography to see the anatomic outline of these internal carotid arteries. So coming to the management, the decision, it depends on all of these that are listed. The first thing is the natural history. Okay, the natural history of specific pathology should be known for the specific patients. Okay, the other one is neurologic symptoms. So those patients who have a full-blown neurological deficit, the management or the modality of treatment is mainly going to be medical, because intervention in these patients like surgical or endovascular is going to be dangerous. The other one is severity of stenosis. Severity of stenosis means that whenever the stenosis severity increases, the likelihood of another attack of stroke and death is higher in these patients. So intervention should be mainly by surgical or endovascular, apart from the medical management. The other one is plaque morphology. When talk about plaque morphology, the plaque morphology, as I've said in the introduction, is important because those patients who have a calcified plaque, they have less likely to have a rupture of the plaque and resulting in stenosis or emboli. But those patients with soft plaque, they have a higher chance of development of embolization. The other one is knowledge of evidence-based guidelines, because the guideline differs in each institutions, and you have to always stick to your guideline, which means it should be institution-based guidelines, not only universal guidelines. The other one is we should always know our outcomes. This is mainly works for interventional radiologists, vascular surgeons, and also those who are working on the area of carotid artery diseases, also in neurologists also. So coming to the treatment option, we have medical management, which includes antiplatelet drugs administration, which is mandatory and it should be lifelong. We have a statin administration, lipid-lowering drugs. This is also mandatory because these two drugs decreases the risk of subsequent development of stroke. The other one is management of hypertension, glycemic control, and control of comorbidities. So these are all the things that you should consider on the best medical therapy. Okay. The other one is behavioral modifications, like you should always advise patients to stop smoking, and the other one is management of metabolic syndrome in general. The other part is, apart from the best medical therapy, is whether these patients need surgical intervention or not. Okay, this intervention could be endarterectomy. Endarterectomy means removal of the plaque from the artery with its edema, or management with endovascular or minimally invasively. You can stent these patients with a graft stent by just accessing from the brachial artery or from femoral artery. So this decision depends on these three main things. Okay, so the first one is the estimated risk of stroke in a particular circumstances. Okay, you have to assess the patient's comorbidity, its clinical scenario, and its plaque phenotype should be assessed. The second one is specific benefits, which means, does the patient benefits from these specific interventions? How do you assess its functional capacity and their life expectancy? Which means a patient whose life expectancy is more than 5 years, even if they are asymptomatic, this plaque should be addressed. But those patients whose life expectancy is less than 2 or 3 years, and still they are asymptomatic, these patients best left with only best medical therapy. Okay, but if they are symptomatic, even if their life expectancy is only 3 years, these patients should be considered for this surgical intervention. The third one is intervention-specific risk, like procedure-related or operator-related risks should be addressed. Okay, this I've already discussed. Okay, let me take you to this table because it explains better for each intervention. Okay, so this is a clinical factor assessment for a patient who has developed a stroke and how to intervene. Okay, so one of the most important thing is diameter of the stenosis. So those patients whose, whether they are asymptomatic or symptomatic, if the stenosis is more than 70%, these patients should be amenable for intervention, whether surgically, open intervention, or endovascularly with stenting. Okay, But if the diameter of stenosis, if it is less than 50%, this patient is only put on best medical therapy. But for those patients, their stenosis is between 50 and 70%, you should assess clinically and the characteristics of the plaque should be addressed. The other one is plaque ulceration. If there is plaque ulceration, they should be intervened. Plaque progression. If the patient has a plaque progression, also should be intervened, which means a patient, once they develop a stroke or if they are diagnosed with carotid artery disease, this patient should be followed thoroughly, initially every 3 months, then 6 months, and every year, based on their life expectancy. Then you have the plaque area, disruptive fibrous cap, and other things. This all should be documented in a patient, okay? The other one is the patient characteristics. What does it look like? Their neurological symptoms. For example, if a patient have only transient ischemic attack with blurring of eyes, with amaurosis fugax, and that symptom disappears within 24 hours, these patients should be given priority for intervention, specifically for surgical intervention, because the risk of development of stroke in these patients is higher. This full-blown stroke can be prevented with carotid endarterectomy or with a stent. But if the patient has full-blown stroke and on neurological examination, for example, if the power is 5 out of 5, they are neurologically, almost silent. So these patients can benefit from subsequent risk of stroke attacks by intervening and by doing carotid endarterectomy, okay? But if the power or their neurological deficit is full, like for example, the power is 0 out of 5, this patient is better to put on them only on best medical therapy, because once they have full-blown stroke with, global ischemia, there is no way of going back. Rather, by intervention, you will end up in development of reperfusion injury, which later on the patient will die because of your interventions and the disease by itself. The other one is history of contralateral stroke. It is said that, if the patient has, a plaque over right side, which results in a stroke on the, on the same hemisphere, the likelihood of having, a plaque on the contralateral side is higher. So this patient should be, investigated with Doppler. And if they have, a plaque over that area, and if the stenosis is like more than 50%, it is better to give a chance for these patients, because the likelihood of development of a stroke in this patient is going to be higher, because it is said that the plaque characteristics in the patient is going to be the same like the contralateral side. The other one is renal insufficiency. It is important because those patients who have renal insufficiency, if they develop stroke, it's not important to, you have to first manage their renal insufficiency and going to intervention with surgical management, because the risk of morbidity in this patient is going to be higher. The other one is smoking history. This patient should ultimately stop smoking before intervention. Otherwise, if they continue to smoke, there is no point of doing, a more complex surgery. The other one is patient-specific factors like, hostile neck, which means, those patients who have, previous surgery over the neck, it's better to treat these patients with, endovascular than open surgery. If they have, radiation-related arthritis, it's better to intervene with endovascular than open, because there is going to be difficulty of surgery on, scarred tissue. If you consider intervention in these patients for prevention of subsequent attack of stroke and to decrease morbidity and mortality, there are two options. One is carotid endarterectomy. The other one is carotid artery stenting, okay? So when do you prefer one of them? So carotid endarterectomy, it was first done like 50 or 60 years back, but the carotid artery stenting has been, been used for the past 20 years, but still, the standard way of management these patients is, endarterectomy, open endarterectomy, because we don't have a long-term data over the carotid artery stents. But still, there are specific scenarios where we choose carotid artery stenting than carotid endarterectomy, and also carotid endarterectomy than carotid artery stents, okay? For example, if the patient has a poorly compensated cardiac ischemia or heart failure, these patients, have a higher morbidity, okay? So these patients will have a higher morbidity and mortality in perioperative period. So it's better to subject these patients for carotid artery stenting than carotid endarterectomy, okay? The other one is higher lesions. Initially on the anatomy, I've shown you the anatomic, classification of the neck. So those who are in zone 3, it's better dealt with carotid artery stenting than open endarterectomy because of its difficulty. Even if there are some, surgical techniques to expose, the proximal part of the carotid artery, it is still better to treat these patients with carotid artery stenting, okay? Scarring, as I have said before, carotid artery stenting. Recurrence, carotid artery stenting. These all things are, important in addressing a patient with symptomatic or asymptomatic carotid artery lesions, okay? So evidence-based selection of therapy is important, okay? So these therapies include best medical therapy alone or plus carotid artery endarterectomy plus best medical therapy, or is it carotid artery stenting with best medical therapy? These all things should be discussed and addressed with, specifically you have to discuss also with the patient, not only with your, so to say something, I'm not going to dive deep into the carotid endarterectomy. I just want to show you the importance of carotid endarterectomy because, based on our experience, it is not that much practiced or that much being done on this area because as a medical, professional, as a general practitioner, as a resident or as a student, I have noticed that carotid endarterectomy is not being done in our setup. It is only we started doing it for the past 1 year. We have done not that much, but we have started doing this carotid endarterectomy, and the outcome is it's good for us at least. But we should always know that as a health professional, the management of a patient with atherosclerotic lesion of the carotid arteries, who has a transient ischemic attack, who's asymptomatic, or who has a full-blown stroke with, who has, in a remission phase for with stroke, these patients is better dealt with carotid endarterectomy because the risk of development of subsequent stroke is higher and mortality and morbidity can be prevented from these carotid lesions, okay? So first it was done by Gebregiorgis, which was successfully done in 1953, which is considered to be safe and effective, and it has reduced ischemic stroke in both asymptomatic and symptomatic patients, okay? So when you consider timing, which is the most important, because as a health professional, you are going to deal with these patients, okay? You diagnose stroke, you start treatment for these patients, you give them, best medical support, then what to do? The next step is, if you can have a carotid Doppler, if the radiologist is available, okay? But when is the time to do carotid endarterectomy and to refer these patients, okay? So after the development of acute stroke, doing carotid endarterectomy within less than 2 days, which means 48 hours, has a higher risk of perioperative stroke and death. So it's not advisable to do it within the first 48 hours. The best time is, after the 3rd day or within the 2nd week of the acute development of the stroke, okay? Or it says that there is no increased risk of development of stroke by the procedure, which means, these patients, when you do this procedure, you are going to clamp the carotid arteries, okay? So the risk of development of, this stroke, which is procedure later, is going to be there for these patients, okay? So you have to outweigh the benefit with, side effects, okay? There is going to be a risk. So that risk should be at least less than 1%. But, for our setup, since it's a beginning of the, the era for vascular surgery, it should be at least less than 3%. Okay, so we consider the intervention should be at least more than 72 hours, but the best time is after the 1st week, okay, which means within the first 7 to 14 days, okay, and it should be dealt if, patients are living the periphery, they're, clinical scenario is not good, this intervention can be done up to the level of 4 weeks, fourth week, okay? But once they have passed the 4th week, the risk of stroke it will be more or less likely to be like those patients who are asymptomatic. So these patients will be addressed like asymptomatic patients. So in general, for those patients whose lesions is stenosis who are asymptomatic with greater than 60% should be addressed with carotid endarterectomy apart from their medical management, okay? And as I have said before, you know, it reduces the 5-figure risk of ipsilateral stroke. So the risk of performing this carotid endarterectomy should be less than 3%, okay? So less than 60%, 3 to 5 years of life expectancy, less than 3% of perioperative stroke will do carotid endarterectomy in these patients. So the classification, this is mainly for the radiologists because they are going to report on the level of or the degree of stenosis. We usually use the NACID criteria, but as a general practitioner, you should be worried about this classification. For symptomatic patients, you know, if it is less than 50%, they are less likely to, you know, benefit from the intervention. But if it is more than 50%, these patients will benefit from carotid endarterectomy, okay? If they have a severe comorbidity, less likely to benefit from carotid endarterectomy because these patients are very highly likely to die of their comorbidities and, you know, with carotid stenosis resulting in stroke, okay? The other one is if the stroke which has resulted in a persistent stable neurological symptom, it is better to leave these patients alone. As I've said before, the risk of, you know, reperfusion injury is going to be higher. And those patients who have near or total occlusion, these patients also should be left alone because if it is totally occluded, there is no point of doing, you know, the surgery. But we are only specifically talking about stenosis, which means there is a higher degree of, you know, occlusion, but the occlusion is not 100%. These are guidelines. You can go ahead with that one. So in summary, so carotid endarterectomy is, you know, established as safe and effective by randomized controlled trials in both symptomatic and asymptomatic patients. It is suggested not treating patients who are asymptomatic with, you know, carotid artery stenting, but carotid artery endarterectomy can be done in these patients. Best medical management is a reasonable alternative to carotid artery endarterectomy, but it shouldn't be, you know, alternative, but it should be an additional intervention. So this is all about approach to carotid artery disease. I'll go and dive into carotid body tumors or carotid space masses, okay? So, you know, carotid body is one of the, not one of, actually it is the largest chemoreceptor in our body. And as you all know, it is located in the period adventitia of the posterior surface of the carotid bifurcation. And, you know, it's considered, whenever it grows, it is considered as one of the paragangliomas. These paragangliomas on, you know, nerve sheaths or nerve tumors are considered to grow not only on that specific area. There are other areas, okay, all over our body, but I'm going to talk about only those who develop in the carotid bifurcation, okay? In the normal anatomy, the carotid body is like 5 mm in size. It has neurovascular supply. It gets its sensory from the glossopharyngeal branch, and it supplies its arterial supplies from the external carotid artery, which is mainly from ascending pharyngeal artery, which is considered to be one of the first branch of the external carotid artery. It has 2 types of cells, type 1, type 2. So in terms of pathology, it could be sporadic, could be familial or hyperplastic, okay? Usually they are diagnosed within the 3rd up to 5th age or decades of your life. If the pathology is familial, they might present at earlier age, and they can also have bilateral lesions. I'm specifically talking about familial lesions, okay? As a risk factor, when you consider hyperplastic, the reason, specifically when you talk about epidemiology, the reason it is common in our setup is not well known, but we consider one of the risk factors is, you know, to the development of carotid body tumors is hypoxia. So most of our patients are, you know, coming from high altitude areas. You know, whenever a person starts to live in a higher altitude, their level of oxygen amount in the blood is lower. So what happens is, because of the low partial pressure of oxygen, this carotid body is a chemoreceptor. We said that it's a chemoreceptor, so it starts to be a hyperplastic tissue. Okay, because because hypoxia, this tumor will be activated continuously. Because of that, there will be changes. Okay, on this image you can see that there is a bifurcation. The carotid body is it's usually situated over here. So the most important thing is, anatomically, you have to know that this is the most important part, okay? Which means, in terms of intervention, we'll talk about later, the only option of intervention is surgery. And doing surgery over this area is dangerous because of it is an overcrowded area. As you can see, you have the carotid arteries, external carotid artery, the internal carotid artery. You will have, the vagus nerve. In this image, you can see the vagus nerve coursing between the jugular vein and the internal carotid artery. And then you have the hypoglossal nerve crossing over these two arteries. And also you have also the glossopharyngeal nerve, the superior laryngeal, which is a branch. And also you can have also accessory nerve. And these all nerves are situated in this carotid space. So doing surgery in this patient is going to be dangerous, but still the only option of management is surgery. So there are zones of dissection, which is mainly important for surgeons who are doing this surgery. But I'll let you the anatomy. I'll let you know the anatomy of these specific things. You see, this is a tumor. Then you have zone 1, which is mainly you will find the jugular vein. Then you have the vagus nerve. Then you have the common carotid artery. The second one is zone 2. The zone 2 is mainly you will have the external carotid artery. You can like the external carotid artery, no problem. You have the distal part of the hypoglossal nerve and also the superior laryngeal nerve. But the most of the injuries that occurs in postoperative is on the zone 3, because it is well overcrowded. As you can see, the proximal part of the vagus nerve, you can see the proximal part of the hypoglossal nerves, the glossopharyngeal nerve, you have the accessory nerves. These all things are situated in a narrow space. So knowing the anatomy is more important, okay? So these are other sites where you can find these paraganglomas, like glomus vagale and other pathologies. So as I have said before, low partial pressure of oxygen will stimulate the carotid body. The carotid body will stimulate the sympathetic nervous system, then the arterioles will constrict. Then the vagus nerve will be stimulated. It results in cardiac response and respiratory responses. So coming to the pathology, even the pathologic carotid body tumors also almost always resembles like the normal carotid body tissue, which is a reddish brown, which is rubbery and well circumscribed. But usually they don't have a true capsule. And these tumors are highly vascular, and they can also invade the adventitious of the adjacent carotid vessels. Okay. And coming to the microscopically, this still resembles normal carotid body architecture, and they are well differentiated. Okay. Malignant transformation, it's not that much. It cannot be predicted on the histology, but the malignancy of these pathologies cannot be said and cannot be predicted based on their pathological appearance. Rather, only clinically we can say that these patients have a malignant carotid body tumor or not. Okay, so which means any kinds of neuroendocrine tumors, clinically they can be diagnosed as having malignant tumors rather than having a benign tumors. So these carotid body tumors usually always they act like a benign tumors. So the most important thing that you should know about this specific carotid body tumors is, even if you don't know that they are malignant, the chance of having malignant carotid body tumors is less than 5%. But even the benign tumors can have an aggressive nature of invading their surrounding structures. Okay, so it is well known for their aggressive nature towards their adjacent structures. So that's why we intervene in these patients. Clinically, most of these patients will have, they are asymptomatic, but if they present with asymptomatic lateral neck mass. It could be right or left side, but it could also be bilateral, okay? Usually this mass is firm, smooth, and lobulated on palpation, okay? But the most important sign that you should always consider is, the Fontaine sign, okay? The Fontaine sign is, it is best described as, a mass which is benign, which moves laterally or horizontally on palpation, but the problem is when you try to move it vertically or longitudinally, it is immobile. The reason behind this is because the mass is situated between the carotid bifurcation, okay? So because of that, the mass is not mobile vertically, but it could also, it is possible to move it horizontally, okay? That is how we differentiate it from other pathologies like cervical lymphadenopathies and other differential diagnosis of lateral neck mass, okay? If you have this sign plus pulsation over or breathe over that specific mass, you should always consider that your top differential as carotid body tumors. The other presentation could be due to compression or local invasion of the nervous, surrounding structures, the vein, you have the esophagus, the trachea also. And most of the time, these patients can have nerve dysfunction. And most of the time, as I have said before, these patients will have non-functional tumor, okay? Because other areas, paranglomas, most of the time they are functional, specifically if you consider abdominal tumors, they have functional tumors. But carotid body tumors, most of the time, they are non-functional. How do you diagnose it? As I have said before, historically, they will tell you asymptomatic neck mass, which has been there for a very long time. And on physical examination, a pulsatile mass, which is smooth, could be lobulated, but which moves horizontally, but it is difficult to move vertically, okay? So differential diagnoses are like congenital lesions like brachial cyst, you have inflammatory disorders of the lymph nodes, you have benign lesions, and malignant lesions also can be considered, okay? So in terms of diagnosis, the best diagnostic tool is image, okay? Doppler can suffice for the diagnosis, but if you consider intervention, it is best to have the, the anatomic outline of these tumors in its relation to the carotid artery. So it's better to have CT angiography or MR angiography or diagnostic subtraction angiography. They say still, as I've said before, it is invasive, so you better choose between CT angiography and MR angiography, okay? But only to diagnose, the Doppler suffices, but intervention, we need CT angiography because CT and MRA can tell you the anatomic configuration of the specific vessels. But unlike the tumors, these carotid body tumors doesn't need to be biopsied, or we don't need fine needle cytology, okay? So as a physician, if you encounter these masses, please don't subject them to fine needle cytology or any kinds of pathologic studies, okay? It's better to have imaging, okay? The reason behind this, as I've said before, it is a very vascular tissue. So whenever you try to do fine needle aspiration, it starts to bleed, okay? Unlike other things, it's difficult to prevent and to stop this bleeding. So it's better to have only imaging study. So pathology study, which is biopsy or FNS, is contraindicated. Biopsy can be sent after excision of the tumor, which means after proper treatment. So this is what you can see on angiography. This is the internal carotid artery. You have the bulb over here. Then you have the external carotid artery. Then over here, you can see a tumor which is situated between the two arteries. And the two arteries are, well spread apart. And we call this one Leray sign, okay? Leray sign, okay? This is diagnostic of carotid body tumors or carotid space mass. The next step is, not only vascular surgeons are supposed to intervene these patients, but if you are a good general surgeon, this can be done by general surgeons, a tumor excision, specifically the first classification. Anatomically, they are divided into three: Chamberlain 1, 2, and 3. Chamberlain 1 can be, intervened by these surgeons, okay? So what does it mean when you say Chamberlain 1? we are talking about, their size and encirclement of the internal carotid artery and the infiltration, okay? Those tumors who are less than 4 centimeter and their encirclement of the internal carotid artery is less than 180 degrees are considered to be 1. But if it is up to 127 degrees, we consider it to be 1, Chamberlain 2. But if it is more than 270, we consider it to be Chamberlain 3. But it is still in A. And there is another classification. I don't want you to bother about the detailed one, but you have to always know that whenever the grade of the Chamberlain increases, the risk of post-op complication with surgery is higher. So that's why it's better to deal with Chamberlain 1, okay? Once it develops into Chamberlain 3, still you can intervene. There are some signs that we saw on the images, but it's going to be difficult and the post-operative complication is going to be higher. So coming to the treatment, as I have said before, surgical resection is the mainstay of treatment for carotid body tumors, okay? Smaller tumors are easier to remove, which means Chamberlain 1 with less than 4 centimeter. But still these tumors may grow to distal into the skull phase, still depending on their, progression into the base of the skull, your intervention matters. And tumors may also develop a malignant behavior. Still, these patients might benefit from, excision of the tumor, but it depends on their metastasis. For example, if they have higher morbidity, a patient who have, multiple lung mets or other sites of metastasis, these patients might not benefit from its surgical intervention, okay? But still, those who have, silent metastasis can still dealt with, okay? The other one is radiation therapy. Previously, it was considered to be one of the mainstay of therapy, but nowadays it has, fallen out because it doesn't help the patient, okay? But the only time that we use this radiation therapy it's only for those patients who are deemed to be poor for operative candidates, like older age with more comorbidities, we consider this radiation therapy. And for those patients who have unresectable tumor or recurrent tumor, because recurrence by itself will make the anatomy, more disturbed. So it's going to be difficult in terms of resection, okay? The other things that you can consider is, pre-operative, chemoembolization, but embolization of this specific feeder of the carotid arteries, which means, as I have said before, ascending pharyngeal is going to be the feeder of the carotid tumor. So these patients can have embolization of these specific arteries, okay? So that it can decrease the size and excision can be, easy. But the excision should be done immediately. You shouldn't wait more than like 24 to 48 hours. So this image, it's just to show you how excision is done. It's more likely you should understand that the external carotid artery can be ligated without any problem, but the problem is you cannot touch the internal carotid artery. This is after excision was done, and there was the mass was attached to the internal carotid artery, and the internal carotid artery also has been resected with a tumor, but the internal carotid artery has been replaced with a graft, which is a prosthetic graft. So postoperative complication, the main fear is stroke. The reason behind this, during dissection, you are going to mobilize the internal carotid artery, which is dangerous. And during mobilization, there is going to be, embolizations, okay, because of the manipulation of the artery. So it can result in postoperative stroke. The other one is bleeding and postoperative hematoma, because you are going to excise a highly vascular tumor. These patients can bleed a lot, and they can also result in postoperative hematoma. But the most common complication is cranial nerve injury, okay? From these cranial nerves, as I have said before, the facial nerve branch, which is the mandibular branch, can be injured. The hypoglossal nerve can be injured. The glossopharyngeal nerve can be injured. Axonal nerve can be injured. All these cranial nerves can be injured, okay? But the most commonly injured one is hypoglossal nerve. But most of the time, this hypoglossal nerve is transient, okay? Which means the lesion will return back, because most of the time it is because of your manipulation with instruments. Okay. The other one is Horner syndrome. It can occur because of sympathetic injuries, but these all can be prevented with fine and neat dissection. So I think this is all about carotid body tumors and cerebrovascular lesions. Thank you.
Thank you very much, Dr. Dawit. That was a concise and interesting session. So we'll directly move to the Q&A. My co-host, Dr. Simon, will shortly share his screen and we can go over the questions together.
Okay.
Okay. So we have about 7 questions. So the first question reads, how can we effectively stratify patients for intervention in resource-limited environments, especially when access to high-end vascular surgery and stenting is limited?
Okay. Shall I continue with the answer in each?
Yes, continue, doctor.
Okay. Okay. So it's a good question. So it's relevant for resources we are living in a limited area, but one thing we should know is that not all patients need sustaining, which is the most expensive consider. Okay. So one thing that we should only understand is that we have a certain in the world where we are living, it's not only the vascular surgeons that are in the carotid endarterectomy. The neurosurgeons who are trained can do this endarterectomy, and other surgeons can do this endarterectomy. The only thing is that we need to have, need to develop a society which is more concerned about these patients, because these patients, when to cover cerebrovascular, have a higher morbidity and mortality, and the cost of healthcare in these patients is higher. So this cost can be decreased by addressing specific things. One of the things is we have to address it by intervention, by doing carotid endarterectomy, specifically who has indications. Okay, so it's right, we have limitations of health professionals. Like 4 years back we have only 1 vascular surgeon. Now we have 10 vascular surgeons. In subsequent years, it's going to be increasing. Okay, so it's better to develop a society which is more related to this specific disease, and it's better to train surgeons on how to do carotid endarterectomy. Okay, it's a very concern, but still I think we can start from the scratch and we can increase our achievement by doing little by little. Okay, the main thing that we should always be concerned is that first, let's have sufficient pool. Let's send these patients to the proper physician, okay, which we have like vascular surgeons. Okay, so we can start with that. Okay, with the next 5 to 10 years, we can have a better center, a better surgeon who are well experienced. So it's a newly developed thing. So it's a good question. So we should all work towards achieving our goal. Okay, so we can increase the health cost care. I mean the cost of health care by development. Okay, that is what I can say. I don't know. I think so. The only thing we can do is let's start from the scratch. Okay, then let's first send these patients. Then we can show that there is a need assessment can be there, and we can show and we can change the health policy. Okay, after changing the health policy, we can achieve our target. That is the only way forward. But we need to show that there is an adjustment in our setup first. Okay. For the second question.
Okay. So the second question reads, in settings where hypertension and diabetes are common, how should we optimize the management of these comorbidities to reduce the risk of progression in carotid artery disease? So you may proceed, doctor.
How it says, how should we optimize the management of these comorbidities? The management is as usual. Okay, so we have to control hypertension and diabetes in every patient who are diagnosed to have hypertension and diabetes, which means in diabetic patient the glycemic control should be So the management of diabetic patients, it starts with glycemic control, okay? So the risk of having macrovascular lesions in diabetic patients is higher. It's not only when we talk about arterial lesions, we are not only talking about carotid artery disease. We are talking about the whole vascular system because these patients are at higher risk of development of atherosclerotic lesions in other parts of, vessels, okay? So the management is the same. Control your hypertension. The patient's hypertension should be controlled. Their diabetics should be controlled. But the best way forward for this management is best dealt with, internal medicine people. But I am from the surgery. But as what I know is, nowadays, AC inhibitors are preferred for hypertension control, specifically those patients who have symptomatic artery disease. And for diabetic patients, it depends on their level of glycemic control, okay? And then whether it is type 1 or type 2. But the question, if I understood it correctly, if the patient is diagnosed at the same time having carotid artery disease for hypertensive disease, it's better to put them on AC inhibitors. But otherwise, the management is like in the patient who has hypertension and diabetes. For the third one, it is how does anatomic arteries influence surgical decisions.
Okay, thank you very much, Doctor. So the third question reads, how does the anatomical variation of the carotid arteries influence surgical decisions?
For example, it matters because, for example, those patients who have, variations, like if they have a coiling of the internal carotid artery, doing, stenting is going to be difficult in these patients. So the best way forward is, you have to go in for open procedure. You have to also correct at the same time the coiling and the kinking in these patients, apart from, removing the plaque, okay? So one thing is that. The other thing is, when you talk about variations, there are so many variations. For example, the patient might not have a fully developed circle of Phillips, okay? So intervention in this patient is going to be a little bit tricky and difficult because you have to counsel these patients. As I have said before, almost 25% of the normal total population have a less developed circle of Phillips. So you have to always tell the patient that during intervention, the risk of development of stroke is there, and it is almost close to 25%, unlike the other individuals, okay? So it matters because your surgical decision is going to be based on your anatomy of the vessel. That's why we say that the anatomic variation is the most important thing while considering your intervention, okay? Next.
Okay, thank you very much, Doctor. The fourth question reads, how do you manage a patient who presents with symptomatic carotid stenosis and has a history of coronary artery bypass surgery or a recent MI?
It's a good question. So these patients, if they have a recent MI or coronary artery bypass surgery, it clearly shows you that the more comorbidity in this patient is higher, okay? So if it is a recent one, these patients most probably they are on double antiplatelets drugs, one thing, okay? The other thing is, these patients, if they have a recent attack of myocardial infarction and or intervention, these patients, if you, subject them for open intervention, the risk of perioperative morbidity is going to be high. We are talking about not only perioperative stroke, okay? These patients also have a higher risk of perioperative, repeated attack of myocardial infarction, okay? We are always talking about vascular incidents, okay? So these patients, if they have a recent attack of myocardial infarction, it's better to deal with this patient. If they have a clear indication, it's better to do, carotid artery stenting than doing open procedure.
Okay, thank you very much, Doctor. The next question reads, how do you follow patients post-CEA or carotid artery stenting procedures?
Okay. So the follow-up, it depends on, there are different strategies in the follow-up because you have different guidelines. But the best guideline is, you have always follow them with Doppler ultrasound. That is the best one, okay? And what we can do is after discharge, you should have on these patients after 1 month, you should have a Doppler ultrasound, see the progression, okay? If there is any progression of or stenosis of the lesion, then you can put these patients after 3 months, then it could be after every 3 months for the first 12 months, then after 1 is every 1 year. This is how you should follow your patients. And the follow-up should always be with Doppler ultrasound.
Okay, thank you very much, Doctor.
So before that,
okay.
Let me add one more thing, okay? So, but
Okay.
during one follow-up, if you have any kinds of stenosis, okay? So usually within the first year, we consider that if the patient has, post-carotid artery endarterectomy, if they have stenosis, we consider it to be because of, hyperplasia. But if the stenosis is severe, this patient should be intervened. But after 1 or 2 years, if the patient develops stenosis, these are considered to be because of disease progression. Okay, so reintervention is mandatory in these patients. Thank you.
Okay, thank you very much for that, Doctor. The 6th question reads, which is preferable between CT angiography and MR angiography for evaluating carotid body tumors and carotid artery stenosis?
Okay. So both studies, shows you the anatomic outline of your artery, okay? But both of them have their own advantage and also they have their own disadvantage, okay? So initially, the MR angiographies mainly, the purpose is, even if it shows you the vascular outline, their purpose is, mainly it shows you the soft tissues, okay? But when you come to the heart, the CT angiography, the CT scan, it shows you the anatomic, anatomy of the vessels clearly. But the problem is if the patient has, associated calcification, it's going to be difficult to outline the anatomy, okay? So for those patients, we prefer MR angiography, but specifically the initial diagnostic tool after ultrasound should be CT angiography. The other thing is, it's all about trained physicians, okay? So most of radiologists and even vascular surgeons, not only in Ethiopia, but also in the Western setup, they prefer and they have a better knowledge of reading and understand the CT angiography than the MR angiography. So one is also the clinicians, they prefer one of the images, okay? So that is the most important thing. But before that, you should always consider that CT angiography also has its own drawbacks, okay? So the choice is, one, it depends on the physician. The other is, it depends on the nature of the pathology, okay? It works for carotid body tumors and also for carotid artery stenosis. But in our setup, it's better to have a CT angiography, okay? Thank you.
Okay, thank you very much, Doctor. The 7th question we have reads, what are the indications for carotid artery stenting and is it done in our setup? If so, which centers provide these procedures?
Okay. So for carotid artery stenting, so far, the indications are the same like carotid endarterectomies, okay? But the only difference is carotid artery stenting is not indicated in those patients who have asymptomatic stenosis, okay? The reason behind this, if these patients have a longer, their life expectancy is higher, we prefer to do a carotid endarterectomy because these patients, long-term outcome is not still well known. There are studies which are ongoing, okay? We have to know their long-term outcome, okay? But those patients who have symptomatic carotid artery lesions, stenting can be done, one. The second one is, if there is a hostile neck, as I've said before, if there is a radiation therapy over the neck because of malignancy or any other thing, if the patient has any previous neck surgeries related to the carotid artery or any other reasons, if the patient has a stoma over the neck, okay, all these patients may benefit from carotid artery stenting, okay? But the indication is, it's the same, okay? The only difference is the patient's, factor, okay? And upon that, we should always consider the patient's comorbidity also. Open surgery has a higher perioperative morbidity than the endovascular intervention, the stenting, okay? So in our setup on the governmental, we don't have this setting, but in the private setting, they are doing this stenting, if I'm not mistaken. I think, I think Axon, the name of the center is Axon, if I'm not mistaken. I think they are doing this stenting, if I'm not mistaken. But in the government, we are not doing this stenting because, as I have said before, it is costly for us. Okay, thank you.
Okay, thank you very much, doctor. The final question we have reads, is chemotherapy beneficial for carotid body tumors?
No.
Okay.
We should all understand that, the only management or the only principle of intervention in patients with carotid body tumors is surgery. Resection is the only option we have. Not only we have, the only options that we should always consider, okay? So chemotherapy and radiotherapy are not used in these patients unless radiotherapy is used in patients, as I have mentioned before, those who are morbid, who have comorbidity, which we not amenable for surgical resection. These patients can have radiotherapy, but still the outcome is poor, like the chemotherapy.
Okay, I'll give the floor to my host, Dr. Tadai.
Okay, thank you very much, Dr. Simon, and thank you very much, Dr. Dawit. You've answered all the questions in a comprehensive and patient manner. So we'll now directly proceed to the post-CME quiz. Okay, so the first question is, which one of the following increases the risk of stroke? A is severity of the ICA stenosis, B is increased number of risk factors, C is soft plaque composition, and D is all. So
I think all of them have got the answer. So the severity of the ICA is one of the most important thing, which increases the risk of stroke. The number of risk factors is also one of the risk factors, and having also soft plaque composition is also one of the risk which increases a stroke. So all is answer.
Thank you. So if you can go ahead with number 2 as well.
Okay, this is a case scenario who is a 55-year-old male patient who was diagnosed with ischemic stroke and was admitted to the medical ward for intervention. So which one of the following it says is not an indication, or which one of the following is a contraindication for carotid endarterectomy or for CA? So those patients, as I've said before, even if they are symptomatic, whether they are symptomatic or asymptomatic, if the stenosis is more than 70%, they should be intervened. A is an indication. B is persistent neurological deficits. It's one of the contraindications, which is the answer, because as I have said before, persistent disabling neurological deficit, if the patient is having this disabling neurological deficit, the risk is higher than the benefit of doing carotid endarterectomy. So we shouldn't intervene in these patients. But for C, like for example, life expectancy of 5 years, later alone for symptomatic patients, even if they are asymptomatic, we should do this intervention. And also if they have resolving symptoms like transient ischemic attack, these are also an indication. So the answer is B, which is disabling neurological deficit.
Thank you. So the third question reads, for the previous patient, he was found to have an indication for intervention. So when is the best time for intervention or the timing of referral? A is within 48 hours, B is within 72 hours, C is 7 to 13 days, and D is less than 6 months. As you can see, most of our attendees have answered C. So please proceed, doctor.
Yeah, so intervention within the first 3 days has a higher risk of stroke. So it's not advisable to do any kinds of intervention after an acute stroke within the first 22 hours. But after that, the risk decreases, so intervention can be done. But the best time is within the first 7 to 14 days or 13 days. Okay. And still, less than 6 months is considered to be a patient who's asymptomatic, but the best time to intervene is less than 4 weeks. Okay, so that we can decrease the subsequent attack or development of a stroke. So the answer for timing of referral and intervention is C, which is the correct answer, 7 to 13 days.
Okay, thank you very much. So the last question is, which one of the following investigation modality is inappropriate or not indicated in a clinically suspected carotid space mass? So A is FNAC, B is duplex ultrasound, C is CT angiography, and D is arteriography. So most of our attendees, so 6, increasing 8, 9, have answered A, FNAC.
Yeah, so it is clear and straightforward. So we should always think that whenever a patient has a clinically suspected carotid space mass, which means a left or right lateral neck mass, which is mobile horizontally, not mobile vertically, we should always send for an imaging, but never try to do cytology or pathologic examination. So the answer is A. So that's.
Thank you very much. Thank you very much, Doctor. So on behalf of Yetena Weg and everyone that has attended, we'd like to extend our deepest gratitude for sharing your invaluable expertise and insights on approach to carotid artery disease. So you've presented the topic in a comprehensive and thoughtful manner, and we appreciate your time and dedication and the knowledge you have imparted today. I would like to thank my co-hosts, Dr. Meron and Dr. Simone, and everyone that has joined us thus far. Thank you.